think that we all, and myself included, have this emotional response to medications and think, oh God, I don't want to take this because even though the risk of having this side effect or that side effect is 1 in 1,000, when you're the patient and as somebody who is a patient, I know that you believe you are going to be that 1 in 1,000 people. So me more than anyone, I understand when people say they don't want to take medicine because they're so afraid of the side effects. I'm going to introduce you today to Dr. Shivam Joshi. Dr. Joshi is a pretty fabulous guy and man, physician. He is a nephrologist, but he's a unique kind of a nephrologist. He's a preventive nephrologist. So that's kind of a new term even for me because he's somebody like a preventive cardiologist. He's trying to prevent kidney disease. So super smart nephrologist or kidney specialist, received his bachelor's degrees from Duke. He did his doctorate degree, MD degree at University of Miami. He did a residency at University of Miami and then a nephrology fellowship at the University of Pennsylvania. I got to know Dr. Joshi or Shivam when he was working in New York with some of my good friends and working as part of the wellness and prevention program at NYU. But he's all over. He's featured in the New York Times and CNN, the Wall Street Journal. He publishes quite a bit in the world of nutrition and its impact on kidney disease. He's the youngest nephrologist to receive the highest award in renal nutrition, which is the National Kidney Foundation's Joel D. Koppel Award, which is incredible. You can see him on Twitter and Instagram, and he has a website called afternoonrounds.com. And just a cool guy, and we just had such a nice conversation. So I'm looking forward to hearing your comments, feedback, questions, and hope you enjoy the conversation as much as I did. Hey there, Shivam. It's so great to see you. And thank you so much for being here on my podcast. I wanted to start by asking you, I've already explained to the audience that you are a nephrologist and what that means, but I thought maybe you could tell me in your words, like you're a nephrologist, like what the heck is that?
Yeah, sure. And I wanted to say thanks for having me. The pleasure is all mine. So yeah, nephrology often gets confused with neurology and other specialties, but we are the specialty of the kidneys, as most people have too. And we deal with, kidney problems. If people have a decline in kidney function, or if they have kidney stones, or they have high blood pressure, which is largely mediated by the kidney, we deal with all those things. What we do not deal with is, for example, taking the kidney out or doing surgery on it. We do love the kidney, but we just aren't trained in that way. That usually falls to a surgeon or a urologist, but everything else comes to us. And a large part of what we do is treating kidney disease, which affects 16% of the population.
No, that's great. Thank you. So let's do some of the basics. And so, because what people may not know is that the kidney is responsible for our urine or our pee. And maybe you can just do a little 2-second video explanation of like how we make our urine, because I think that that's something people don't fully understand about, how we filter the blood and we make urine. And that would be awesome. I know I don't mean to challenge you there because it's sometimes making things super simple for us is hard, but humor me.
Yeah, that is quite a challenge. How do we make urine? There's two parts. There's a filtration process, like a filter, like how if you took a colander and you're washing vegetables or something like that. And then there's also this absorption secretion phase where we're absorbing good things and secreting bad things. And that's essentially how the kidneys make urine, because they magnify this millions of times. And then each little drop coalesces and then you make liters of urine per day. And then the way I explain kidney dysfunction is that imagine if you didn't make urine. Imagine if that urine just stayed in your body and, you would get swelling, you wouldn't feel good, all those toxins would never come out. And that's what dialysis does, is that it gets the toxins out when the kidneys don't work.
No, that's great. So That's exactly right to sort of think about it is that the job of the kidney is to be the filter. So it cleans out your blood and it makes sure that you, and it concentrates all of the sort of bad toxins and puts them out into your urine. And without it, as you said, is that you get all sorts of symptoms and swell up. And if your kidneys don't work, then eventually over time they can get damaged and you stop making urine, and then you have to get dialysis. So what causes the kidney to become damaged?
Yeah, that's a good question, and it's not surprising. The number one cause is diabetes. Diabetes is really a terrible disease. It's a scourge for society. It's a scourge for the body, and that's the number one cause. And then right after that is high blood pressure. And I didn't learn this in medical school, or if it was taught, I missed it. But I learned this in residency, and it was this fact, learning this, that kind of changed the arc of my career, realizing that it wasn't something autoimmune or high blood pressure and diabetes are largely within the realms of our control. These are largely preventable diseases.
Yeah, so it's interesting, right? So I do agree with you. Like I remember in medical school when we learned about kidney disease, you learn about all these like crazy things that can happen to the kidney, and you think, oh my God, that's why everybody has kidney failure. And then you realize that actually those sort of odd or atypical and autoimmune causes of kidney disease are extremely uncommon, and that just some of the basics like high blood pressure and diabetes are the things that are actually damaging our kidneys the most. And maybe you could explain why that is. Like, why do diabetes and high blood pressure damage the kidney?
Yeah, so the kidney is a sensitive filter. It does not like changes in blood pressure, either too low or too high. So when blood pressure is high, it damages that sensitive filtration unit, and it causes scarring, and then the kidneys don't work. In diabetes, it's actually the high sugar. It starts causing these changes first in the glomeruli and then later in the rest of the kidney, that causes these changes that ultimately also lead to kidney failure. So for people who do have high blood pressure or diabetes, the important thing is to keep those things under control, both blood pressure and blood sugar.
So you explained to me before we got on the recording that at one point you had considered being a transplant nephrologist, which is to somebody who helps with the process of when the kidney fails, of how to get it, whether they're a candidate for a new kidney. And I wonder can you tell everyone why you shifted and why you now are not doing that second fellowship, and you're doing preventive nephrology, and what does that even mean?
Yeah, so I didn't pursue a transplant fellowship, another fellowship after my nephrology fellowship, because I wanted to focus more on preventing disease. Transplant fellowship trains a kidney doctor like myself to then take care of specifically of patients who've received a kidney transplant. And I wanted to focus more on preventing kidney transplants. The work that transplant nephrologists do is great, and I have many friends that are transplant nephrologists. But what we need more are preventative nephrologists, because there just aren't enough kidneys to go around. And even if there were, we shouldn't let things happen. Even if we can treat it, we should work towards preventing it, because even the treatment isn't the same as holding on to one's own health. And not to mention the cost to patients, society, time off work, complications. So it's really important. An ounce of prevention is worth a pound of cure, said a famous man from Philadelphia. So that changed. Learning that the common causes of kidney disease are largely preventable changed my path, and ultimately that led me to not pursue a second fellowship. And then I wanted to work on prevention. Preventing kidney disease, preventing the progression of kidney disease. It's not a recognized specialty, preventive nephrology, but there's a growing body of nephrologists like myself who are advocating that we do need this. We need more recognition. Preventative cardiology is probably a decade, maybe a generation ahead of preventive nephrology. So we are envious.
Yes, it's taken some time, but we do have our own area and niche now, thank goodness. And I'm sure nephrology will be on its way. And so I I'm glad you're part of that group. It's very special. So, you know, a lot of times people ask me things about kidney disease where they'll say, well, you know, if I already have mild kidney disease or moderate kidney disease, does that mean I'm doomed to have dialysis at some point? And is there a way to correct it? If you have some level of kidney disease, can you correct it? And what are the best ways to correct kidney disease?
Yeah, so it depends on the cause of the kidney disease and then your trajectory. Some causes of kidney disease inevitably lead to dialysis. For example, most cases of polycystic kidney disease, fortunately, lead to people being on dialysis in the fifth or sixth decade of life. Whereas other causes of kidney disease, like diabetes, do not necessarily lead to someone being on dialysis or kidney failure. Dialysis is the number one most common cause. So if you do have, diabetes is the number one most common cause of patients being on dialysis. So if you have diabetes, you definitely want to be mindful of the effect that it has on your kidneys. But again, it depends on the cause and then the trajectory. So if you have something that you could potentially modify, like diabetes, then the next thing you want to look at is where your creatinine is going. If creatinine is that number that we do as doctors to look at your kidney function. We take that number off a blood sample and then put it in an equation to calculate roughly your percent kidney function. This shows up on most lab reports as a GFR, glomerular filtration rate, or eGFR is estimated glomerular filtration rate. And that number, if that number keeps declining, the percent kidney function or eGFR, then that is what is a good predictor of whether someone will need to be on dialysis. And that's what we try to stop and prevent.
So are you saying, Dr. Joshi, that if I correct my diabetes and improve my blood pressure, that I have a chance of not getting worsening kidney disease?
Absolutely.
Holy moly.
Absolutely.
Like, there it is. You know, there it is, folks. You know, that's it. Like, you know, because we talk about this so much in my clinic as well, of course, as a cardiologist, is that I think people don't realize that the course is not set, right? And so, like, just because you have a diagnosis does not mean that you are going to go on this path right to this point, but that there's so many ways that you can correct and fix and change your course. So like, okay, I've had bad behaviors and I have diabetes and high blood pressure now, but wait, I can turn that curve so I can actually go back the other way and maybe not reverse it, but certainly stop it from getting worse. Is that safe to say?
Right, exactly. Exactly. You definitely can determine how much fuel you're adding to the fire, and you have the ability to even extinguish the fire depending on your lifestyle choices.
Yeah, I think that is one of those moments where I love people to hear that, because I think sometimes even more than heart disease, people are afraid of the kidney disease, which, you know, as I'm biased or maybe not, that the heart is the most important organ of the body. And we always joke with the neurology team and they're like, well, it's really the brain. No, it's the heart. And so anyway, so just dumb doctor humor, but you know,
Well done.
but I think that it's important for people to hear that kidney disease is something that you can stop and that this is not inevitable. I do have patients that often will say, gosh, you know, my nephrologist told me I have stage 3 or stage 4 kidney disease. And I think these are tricky terms that nephrology uses, because I think people really do feel doomsday when they hear I have stage 3. Can you do a little explanation on the stages of kidney disease, and not necessarily the numbers as much as, you know, what do they mean in terms of what are we looking at in terms of maybe severity of GFR and then sort of severity of reduction of GFR, and then maybe and are you in stage 3 for the rest of your life, and can that actually get better? And then what's like the worst stage, and what does it mean when you get dialysis?
Yeah, so there's 5 stages of kidney disease, and it's really for us as nephrologists and physicians to keep track and kind of give some sort of categorization to people. Because when we say kidney failure, which is an outdated term, when we say kidney disease, It could mean a lot of different things. Someone could be in stage 1 and have really mild disease, or someone could be in stage 5 and, maybe being prepared to start dialysis. So stage 3 is kind of in the middle. It's moderate kidney disease. Stage 4 and 5 are considered to be advanced kidney disease. And a lot of people are actually in stage 3, less in stage 4, and then even less in stage 5. Stage 5 is called end stage kidney disease, because it's the last stage. And then you can be on dialysis or you cannot be on dialysis. You may have just enough to get by, but you may tip over just with time, or with your blood pressure going up, or maybe you got hospitalized for pneumonia, and then that could tip you over into needing dialysis. So those are the stages. But it's important that if you recognize and you have certain stage kidney disease, that you are asking the appropriate questions. What can you do to prevent the disease? What can you do on your own in terms of lifestyle and medications, and seeing doctors to make sure it doesn't progress? Because I don't like seeing patients on dialysis, and patients don't like being on dialysis. So we definitely want less dialysis in general.
That's great. And, and 50% of dialysis patients actually die of heart disease. And so we want to get people before they get on dialysis and really be very proactive in terms of treating both all the vascular disease and all the diseases of the heart and kidney. So that's good. So, okay, so inquiring minds want to know, what can we do so you said diabetes and high blood pressure are the biggest risk factors for kidney disease. What can we do in our day-to-day, and you said lifestyle changes, to decrease our risk? Like, how do you talk to your patients and what do you advocate to them?
Yeah, so it all goes back to healthy lifestyle habits. So eating healthy, eating foods that are good for your whole body. Foods that are good for your heart are the same foods that are good for your kidney. We may not agree on what's the most important organ in the body, but we agree that the most important foods are the same for the kidney and the heart. So eating those healthy foods goes a long way. And that's what I try to tell patients, and that you don't have to eat a different diet for your diabetes, different diet for your heart, different diet for your kidneys. You can eat one diet, which is a diet that's predominantly focused on whole plant foods, fruits, vegetables, nuts, whole grains, seeds, legumes. These things that are some of the healthiest foods on the planet. So it's not a surprise that they are healthy for you when you actually eat them. So diet, exercise, very important. Cutting out substance use, smoking, taking the medications as prescribed, which is important, because just because you switch to a healthy lifestyle overnight doesn't mean that the diabetes is gone or high blood pressure is gone. And I've seen plenty of patients over the years that are appropriately motivated, but underestimate the severity of their diseases and stop taking their medications. And as a result, their blood sugar goes up, their blood pressure goes up. And when I see them in the office, I have to do a timeout and say, I would love to talk about the lifestyle change, but you're putting yourself at risk for a heart attack or stroke or something else if you don't take the medications that you need to. We'll taper them down in time, but you can't just go cold turkey. So medications are really important. Even if you don't like them, even if they're big, even if they don't taste good, even if there are a lot of them, you still need them until you can safely get off of them. Seeing your doctor, following up with them, and then also avoiding some things that could cause you trouble for your kidneys, like NSAIDs, which is a class of medications that treats pain, like Aleve, ibuprofen, Motrin. They have a known side effect of causing kidney damage, and people with existing kidney disease are more susceptible to that.
So remembering, anti-inflammatory drugs, as Dr. Joshi has said, and they're not to be once in a while. Taking a little bit of ibuprofen is okay. It's not going to damage your kidney. The key is we're talking more about these chronic use.
Exactly. Yeah, thanks for clarifying. Yeah, it's more of the chronic, repetitive, high dose 3 times a day. And we are seeing a little bit more of that because of the awareness about the use of opioid medications and their side effects and overdoses. So we are seeing a turn to using more NSAIDs, so these anti-inflammatories, but heavy use of them can cause kidney problems.
Good. Yeah, I'm glad you said that. I also like that you highlighted that medications are important. And this is something that is something I struggle with a lot in my clinic. And in when I give talks, people say, well, I eat plant-based, and that means that I can stop all of my medications, and I'm going to be fine. And I think that's super important that you highlighted that, because that's not exactly how this works, right? Is that, you have worked, and I always remind people, like, for 20, 30 years, you've eaten a certain way in your body, or you've had this illness for 20, 30 years. It's not like this, that it's going to go back to being normal because you started eating plants. And it takes time. And I always tell people, you have to honor the process. Like, it takes time to kind of heal your body, and that initially our goal is to sort of get you on the right medicines, control the problem, and then as you're changing your diet and it's getting better and better, slowly and slowly we're able to taper down those medications. Not for everybody though, but for most people, people can come down off medicines, and not everybody's going to come off medicines, but certainly people are going to get a lot better by just making those lifestyle changes. But I just really think that's super important to highlight the importance of medications, that medications are not the devil. Like, they work and they are effective, and we can't be so purist sometimes that we can only say that this is the only option, because not everybody's body works the same, and there's imperfections and it's okay. Like, it's not failure to have to take medication.
Yeah, agreed. And it's a weird twist of human psychology that when we don't have medications for something, we want medications. And then when we have medications for it, that we don't want to take them, or we misconstrue the risk-benefit ratio of said medications. There was a time, for example, FDR, he died from having high blood pressure. I teach that to the med students. And at that time, there was no treatment for high blood pressure. Now we have treatment for high blood pressure, but a lot of patients don't take their medications. I was just reading a paper that came out in JAMA that less than 40% of hypertensives, I believe, are controlled with a blood pressure at goal, which is so unfortunate. And we're now 80 years past when FDR passed away, close to it. But it's because we get caught up in the side effects of medications, or concerns, and we don't see the bigger picture, that we're preventing a painful death or a life of suffering.
Yes, I'm so glad, yes, that you said that. And I think that we all, and myself included, have this emotional response to medications and think, oh God, I don't want to take this, because even though the risk of having this side effect or that side effect is 1 in 1,000, when you're the patient, and as somebody who is a patient, I know that you believe you are going to be that 1 in 1,000 people. So me, more than anyone, I understand when people say they don't want to take medicine because they're so afraid of the side effects. And I still struggle with that personally, with sort of this worry about medications. But I always try to remind people that our goal is to be on as few medicines as possible, but not at the risk of letting our illness sort of take over and debilitate us. And then sometimes there gets to be a point where things get too bad, and then you end up having to weave more and more medicines where it may have been controlled better at a lower dose. So really important to highlight that medicines are not the enemy, and that we can use medicine and dietary and lifestyle changes together. And as one gets better, the lifestyle gets better and for longer, then usually those medicines come down, which is the best thing about making these lifestyle changes. So if you tell people that they should eat more plants, which, obviously I am a huge advocate and a fan of that. There's 1,000. So, I've been in practice now 15 years, and I will tell you that, there's always the constant joke that every cardiologist's nemesis is a nephrologist. And every nephrologist would say the same thing about a cardiologist, because we're always giving medicines. And then we say, oh, kidney doctors, please come fix this. We did this. And then the kidney doctors always laugh at the cardiologist, like, well, you're giving them all this med that does that. And we just say, just fix it. So it's sort of a constant sort of joke that happens. But one of the things that does drive me crazy about nephrologists, and I'm sorry to say that, is that, they people, they worry so much about the eating of plants. because we advocate eating mostly plants or in a plant forward or plant-based diet, and sort of eating, as you pointed out, legumes and lots of greens. But all of those foods are high in potassium. And nephrologists are often will say, in every place I've ever worked, that, well, this patient can't take this medication or eat those foods because they're too high in potassium. And I have many patients who say, oh, I'm not allowed to eat beans because they're too high in potassium, my nephrologist said. Can you talk a little bit about that?
Yeah, so I think we both agree on that when we get frustrated by nephrologists telling us that, and I've even heard that myself. But on one side, it does frustrate me, but on the other side, it kind of makes me happy that that nephrologists at least know that much, and patients know that much too, even though because we don't, in general, most physicians don't know a whole lot about diet. So even to know this, and this was the standard of care for several decades, and it's well entrenched in society. And it's only now, within the past 5 years, that there's been any sort of research coming out on this issue of potassium in food. So if you are a patient or a nephrologist listening to this, there is research coming out, and your treating provider may not know this. Maybe your nephrologist does, but maybe your dietitian doesn't, or your dietitian does, or your nephrologist doesn't, or you may be hospitalized, and then your doctor may say some things different, or a nurse may come by and tell you. And that's because things are changing. We're in this paradigm, we're at this moment in time where the paradigm is changing, that we were taught bananas are high in potassium. Patients with kidney disease cannot eat them. We as kidney doctors have to tell our patients with kidney disease that they can't eat them. And then, so on and so forth. Everyone else says the same thing. There's handouts about it. But now things are actively changing. I was just reading a paper on this, and I was reviewing another paper on this. So as we speak, minute by minute, people are publishing and writing, and it's going this huge transformational shift that we can eat plants. Yes, you can eat plants. But there are some caveats to it. You should any sort of dietary change that could result in a rise in your potassium should be monitored. And it's not because plants will cause potassium, is that you may walk away from this podcast thinking that you can drink juice. Fruit juices are one of the worst things you can do in terms of potassium, because they will raise your potassium. So there are some
and your blood sugar, and they're not good for your heart, and they'll make
exactly.
Yep. Sorry.
Exactly. No. Good. Right. We have to remember the second most important organ in the body, which is the heart. So, so there are some culprit foods that are bad: juices, sauces, dried fruit. Also, potassium supplements or salt substitutes that have potassium are not good. But if you're eating a salad for a large part, you can have a salad if you have kidney disease. Even if you're on dialysis, you can have a salad. What we're now learning is that not all that potassium is absorbed. The bowels the intestines play an important role in regulating this potassium and helping us excrete it out with bowel movements. But if you're constipated, for example, then that could lead to problems. So then you're not able to take advantage of the body's own homeostatic mechanism to regulate potassium, even if you have kidney failure. But we are learning a lot. Things are changing. Patients with kidney disease can eat plants. There are some caveats to it, and it's best to make sure you're doing it safely and with appropriate supervision, which is not always easy to find.
Yes. And so I love that. And maybe you could say those things that are high in potassium, or maybe things that, if you have kidney disease, again, if you have a normal kidney, eating these foods is not a problem. But if you have kidney disease, and you're worried, or you've been told that you should watch your potassium, can you just say those one more time for everybody, the things that are highest of worry?
Definitely. The fruit juices like OJ, apple juice, sauces. Big one is tomato sauce. A lot of potassium in there. What else? Dried fruit. You're just eating a lot of fruit, and you can exceed your body's ability to get rid of this potassium. Salt substitutes, vitamins and minerals with potassium can also do this. Sometimes people add potassium, take potassium because they hear it's good for the heart or the kidney, and then they overdo it. That could lead to problems. Those are the big ones. And then there's certain foods that are just a little bit higher in potassium that you have to be mindful of that could get into trouble. Some people say potatoes, some people say tomatoes. But if you're just eating a salad, or if you're having a bowl of fruit, or you're eating a cup of beans, these are all things that we should tell our patients not to eat. You're not going to get into trouble. Smoothies are another example where you're just blending and it makes it really easy for the body to absorb potassium. So you want to avoid smoothies as well.
I think that this is great. So it's the difference between eating an orange and having orange juice. Like you can have an orange, but when you have an orange juice, I always tell people, how many oranges does it take to make orange juice? Well, you take 8 to 9 oranges to make
Exactly.
to make orange juice. There's no fiber in your orange juice, and it's just concentrated amounts of potassium and sugars. Why would you do that? Just eat an orange. So I think it seems to me that you're saying similar to what I say, which is it's okay for a kidney patient to eat a salad, to have fruits. It's just that it's these highly concentrated forms like dried fruit and sauces and shakes where you're removing a lot of the fiber and you're adding in loads and loads of concentrated amounts of potassium, which then can cause too much burden on your kidney.
Yeah, exactly. I love orange juice, but I only limit myself to once or twice a year. But so I understand the craving for it. But yes, exactly. It's you're putting several oranges. You're constantly getting all that. It's basically potassium concentrate that you're just gulping down, and people might have a couple of glasses at a time. It's interesting that what we have conceptualized as a normal breakfast, like OJ, bacon, eggs. What is very different than what we should really be eating for long-term health.
Amazing, right? And what would you say? So one of the things that I often talk to my patients about who have high blood pressure is I'll tell them to limit the amount of sodium that's in their diet. We kind of talk about processed foods in the American diet where it has so much sodium in it. We really want to just reduce that. What would you say? But then we eat more, and I always tell them to eat more potassium-rich foods. Can you reconcile that with that comment that I just made, with the fact that some people have to restrict their potassium, so that everyone's clear when they have to restrict their potassium? Because I just want to make sure that that's very clear, that not everybody has to restrict potassium, and who does.
Right. So if you don't have kidney disease, you went to the doctor, or if you even pull up your labs and you see your eGFR is above 60, then for all intents and purposes, you don't have clinically significant kidney disease. You may see that, your eGFR is 73 and you fall under the categorization of CKD stage 2. But previously we weren't even reporting these values, and everyone was reported above 60. And for the most part, everyone was considered to not even have kidney disease. If you have clinically significant kidney disease, so I'm saying CKD 3, 4, 5, then you want to be mindful of eating those foods that I mentioned: this juices, sauces, dried fruit, potassium-containing supplements. You don't want to overdo those things, because then you may run into problems with potassium. And something else we should say: if you're someone that already has issues with potassium, you definitely may, from a medication or something, you may want to, not may, but you should have your potassium checked as you make a dietary change. What we've seen in the literature is the people most susceptible to developing high potassium levels while eating plant-based diet are those who've had a history of high potassium level. And that's just because because they have this history, they're likely to have high potassium levels again at any point in the future. And that's just because maybe their body is not handling potassium in a normal way. It could be constipation, the medications. So those people definitely need supervision from their doctor and should be tested. For everyone else, what you meant, your point is a good one, is that we should be cutting back on sodium and eating more potassium in these foods because it helps with blood pressure and cardiovascular outcomes. Back in the Paleolithic era, we were eating more potassium than sodium. Now everyone's eating more sodium than potassium.
Yeah, so let's speak to that, a little bit of a shift there in terms of sodium. And, it reminds me of I don't know if you follow on Twitter, Dr. Glaufikin, because he's like the
Yes,
funniest guy ever. And he walks around with, as a nephrologist, he's always carrying the salt shaker, or the
right.
salt, the container always just makes me laugh. So, let's talk about sodium. What is a good, so, I always think of the amount of salt a person takes in as a U-shaped curve, but there's many people in the plant-based world in particular that want to be SOS free. And we all know that, first of all, there's natural sodium in most of the foods that we eat. But is there a number in your mind that you use? And I know the guidelines as well as you do, I think, which is that it's kind of confusing, but how would you guide people in terms of the amount of sodium that you should take in? And should people take out all of their sodium? Is there any room for sodium? And so what is and maybe just speak to a little bit of what the average American is eating, et cetera.
Yeah, so I believe the average American eats 3.4 grams of sodium, but it's clearly more than we should be taking in, and then there's people on the higher end of that reaching even 10 grams. But the amount that I tell my patients to, and a lot of them have issues related to sodium. They have kidney disease, they have swelling, they have high blood pressure, they have kidney stones, or heart disease. I tell them to limit it to about 2 grams in the way, or 2,000 milligrams. And I tell them that if you can't remember the year. We're in year 2022. That's close to 2,000. So if you limit yourself to less than 2,022 milligrams, you should be okay. And that, and then it gauges people. And what I hear from people, probably out of the 20 people or 30 people I told this last week, every single one of them told me that they do not add salt to their foods, which is fine. It's valid. But what none of them do is read the nutrition label. What they're not realizing is that the food's already been added for them. And patients know not to add salt. But the thing is that they're going to KFC, for example, or they're eating French fries, or they're eating these things, pretzels, that are extremely salty. And they're not realizing that these foods have a lot of salt added to them, and they need to read labels and watch out.
I love that you said that. And also, even when you're reading the label, for those who are reading the label, people maybe don't realize that what the serving size is. And so I often find that people may look at the serving size and say, oh, 1 ounce of whatever X only has 240 milligrams of sodium or whatever it has. But they don't realize maybe that they're actually eating 3 servings. And so they're getting a huge amount of sodium in that food. And so noting how much a serving size is very important. And so reading a label is super important, and it's required by law to document the amount of sodium in the product. So anything that has that you're buying off the shelf in the grocery store from at least the 3/4 of the middle should have a sodium label. Now, obviously, your fruits and vegetables won't have a sodium label on them, but the amount of sodium, natural sodium, that's in those fruits and vegetables is actually quite low. Can you speak to that a little?
Yeah, so fruits and vegetables are very low in sodium, and they help because they're low in sodium and higher. I don't want to continue this myth that they're high in potassium and this will lead to high potassium levels in the blood. But because they're low in sodium and have more potassium, they're really beneficial for lowering blood pressure. And I empathize with patients. It's really confusing to keep track of, read the label, understand the serving size, figure these things out, and then when you go to if you go to a restaurant or you're ordering something, it's not even disclosed. You have to go to this website and you have to look at it, and you may not even get signal on your phone. So I think it's really helpful to refer for the providers that are listening, healthcare providers, to refer to a dietitian. I think dietitians are really helpful in this, and especially if physicians are very time strapped. Dietitians are helpful in reviewing 24-hour dietary recalls, counseling on serving size, teaching about nutrition labels and things like this, which is tough to do as physicians when you only have 15 or 20 minutes for a follow-up.
I like that. And I like that you said that. And also to remember that Medicare will cover a dietitian for only 2 criteria. One of them is renal or kidney disease, and the other is diabetes. And so nephrologists and diabetologists should really be using that resource regularly. In fact, we published a paper on this among cardiologists, that the number, and we struggle because Medicare won't cover for a cardiac diagnosis, which is awful, and hopefully will be changing. Certain payers are paying, but Medicare will not. But if you have a diabetes diagnosis or kidney disease diagnosis, then Medicare will cover a dietitian, and we have to use that resource more often. And it's not something that we do enough of as physicians.
Right, you're absolutely right. That's the other issue, is that getting access to a dietitian is not always easy if you don't have the appropriate diagnoses.
Yeah, it's so tricky, so tricky. Okay, so Shivam, this is amazing. I think people are getting a lot out of this. I'm just going to round this out with a couple more questions, and then I'll give you a break. So one of the things that people often will ask is, how much water should I drink? What is the right amount of water to drink? And is there a number in your mind, or the amount of urine output that or frequency of urine output? What do you use as your measure?
I say at least 2 liters for most people, unless you've been explicitly told by your physician to restrict the amount of water you're taking, maybe because you have liver, kidney, heart problems. But in the absence of that, 2 liters is a good benchmark. Some people need even more. If you're out in the Florida sun doing yard work, you probably need more because you've been sweating a lot, so you may need even 3 or 4 liters that day. But the idea is to actually get your urine to a clear light yellow. And that's when you know that you've been drinking appropriately enough. It also helps you reduce your risk of kidney stones. And it kind of gives you your own personal gauge. Am I drinking enough water or not?
That's great. Right. So I think that people need to maybe not focus so much. It's good to have a number in your head that I'd like to aim, and sort of keeping those 32-ounce bottles and then drinking them. And if that helps you, that's great. But that there's not necessarily a set number of, in fact, I looked this up one point, and this 8 cups a day water thing is not based on a whole lot of anything. And so really we want to flush the kidneys. We want to have sort of that clear to light yellow urine. But that should be the focus more than anything. And rather than sort of how many, again, if it's helpful to people to say, well, I do better if I know I have these 3 jugs. Yes, drink that. But it maybe for those of us who maybe don't do as well with numbers, I frankly just do better with just check your urine. Some people say, oh, I don't look at my urine. Look at your urine. Look at your urine. You pee. Look at it. If it's the right color, if it's clear to light yellow, you're in good shape.
Yeah. If it's really dark or orangey, you probably need a little bit more water.
Yeah. So that's good. And is there a frequency of urine output that somebody should be looking at? Some people will say they can go the whole day and they don't urinate. Is that normal? Is that okay?
Yeah, I've heard various variations of this. If you're peeing more often than every 2 hours, you might have a bladder problem or a kidney problem. If you're not peeing all in a day, or you notice a sudden decline in urine, you may want to get that checked out. Older men are particularly susceptible to this because of the large prostates. They're peeing fine or relatively fine one day, and then they stop peeing, and then that's something to get checked out. But you want to be peeing a couple times throughout the day, and like I said, you want to make sure you're drinking enough water so you have urine to urinate, and that it's coming out clear to light yellow.
And just also to note, thank you, that diabetic patients often will urinate more frequently because of their elevated sugars. And that can be something to kind of keep an eye out too for, is that if you're a diabetic and you're urinating more frequently, to monitor your make sure you're checking your blood sugars.
Right. And those who take water pills will also be urinating more frequently too.
Right. Yeah. And also women who've had multiple children, and there are other caveats to this that, when you don't have as much a strong pelvic floor. So again, there's everybody's different, and there's lots of variations. I think the key is not to worry. Certainly not urinating maybe all day is probably too infrequent, but maybe just focusing on that color of that urine is the most important thing to focus on. I'm just going to ask you one last question that I had the other day, actually, which I think is a good one, and that's why I'll bring it up. Somebody asked me the other day, they said, my doctor told me my sodium was low. Should I just eat more salt?
Yeah, so generally that is not the case unless you've been told to eat more salt. There's some specific situations where people do need to do that. But if that's the situation, then want to definitely be checked out and figure out why. It could be a sign of liver disease, heart disease, kidney problems. And then usually the issue is too much water already in the body and then to get it out. So those people, it becomes tricky. And for those people, seeing a doctor like yourself or myself is appropriate. So said person can be appropriately managed.
Yeah, so very important that it's usually a problem with the water. When this person's sodium is low, it's a sodium water different ratio that is off usually, and that means there's usually too much water, rather than a person should be eating more sodium to make your sodium go up. In fact, that doesn't work, and that we should discourage that. And then maybe I'll just finish with one more question. I lied. I said that was going to be the last one, but I forgot to ask you because you published a lot on the area of protein, and protein in high protein diets. Maybe you could just speak briefly about high protein diets and kidney disease. Is this something we should be worried about? I'm thinking about all the bodybuilders out there, and should they be worried about their kidney? So two different things, I guess. Is a high protein diet in a normal kidney a problem? And then the second thing is high protein diet in a abnormal kidney a problem? And then maybe taking the counter of that and saying, is there such a thing as too low protein for the kidney?
Yeah, so it's a little bit easier to address for patients with kidney disease. For patients with kidney disease, most people agree that too much protein is bad. And actually the guidelines reflect this. And they say to take in a normal amount of protein or something on the lower end of normal to so that you're not in a catabolic state where you're not getting enough protein and you're nutritionally deficient, but you're not overdoing it. So that's usually between 0.6 to 0.8. If you have kidney disease and you're trying to figure out the number, definitely see a renal dietitian because the number can vary. And that's
can you just clarify kilogram. What that number means? 0.8, 0.6 to 0.8?
Yeah, so 0.6 to 0.8 grams per kilogram of protein. Like I said, that it's based on ideal body weight, so getting the math right can be a little tricky. So definitely see a dietitian or a kidney doctor like myself to help tailor that number for you, and especially if you have higher needs, like you're recovering from surgery or a burn or something like that, or you're athletic, you might need even more protein. But the general idea is that you're not overdoing it because the kidneys struggle to handle the protein, and that protein can potentially be damaging. By kind of revving up the kidneys to process it more, filter it out, and we don't want to do that when they're already ailing. For healthy kidneys, there is a debate, an ongoing debate that rages to this day with many strong believers on both sides. I used to be a strong believer that high protein diets have the potential to cause kidney dysfunction. I've since softened my stance and moved toward the middle ground, that I think that if you have completely normal kidneys and you've been checked out, eating a high protein diet should be okay. But if you don't have to eat a high protein diet, definitely don't go out of your way to do so, because we don't know for sure. We're basing this off observational data. There's limitations to it. None of them last a lifetime. They're a couple of years at most. And so we don't know for sure, but another way to say is that we don't have good evidence to say otherwise right now. So that's what I say.
Yeah, I like that. So the key, to remember there is, so if you have kidney disease, so again, we're looking at those stage 3 to 5 primarily, eGFR under 60 patients, those patients will likely have to restrict the amount of protein or be more conscious of their protein intake and not go out of their way to add too much protein. Whereas the patients who have normal kidneys, especially again, these are those often see these bodybuilders are the people that we typically are going to see in our clinics, or at least in mine, and that even if they're taking a higher burden of protein on, their kidneys typically should clear that protein and should be fine, but we don't have enough information.
Right. Right. And if the other caveats are, if you are in that situation where you are eating a lot of protein, you're a bodybuilder and you're eating, 2.5 or 3 grams of protein per kilogram per day, a really high number, be sure that your kidney function is okay. See a doctor, get the lab work, make sure they include urine testing so that you really get the full picture of kidney function. And then certainly if you have diabetes or high blood pressure and taking medications, not the best idea to eat a high protein diet, because diabetes and high blood pressure, number 1, number 2 cause of kidney disease respectively. So you don't want to make a bad situation worse.
Wonderful. Okay, Dr. Joshi, you've been awesome. So tell the audience where, so Shivam, I've known Shivam, actually this is the first time we're meeting Zoom to Zoom, which is fun, but we known each other sort of through the grapevine for some years. And Dr. Joshi used to work at NYU with some of my good friends over at NYU, and now has moved to the greatest city in the world. No, I'm kidding. I never thought that about Orlando until I moved here, but I do really love it. And I'm so glad that you have come to Orlando. Maybe you can tell everybody where you are and where you're working, and how they can find you.
Yeah, so I work at the Orlando VA. So if you're a veteran with kidney disease, I'd be happy to see you if you're in the Orlando area.
And it's the most gorgeous VA, by the way. It truly is the best VA I've ever seen.
Yeah, it is a nice place to work. It's a nice place to actually be in, which cannot be said for many hospitals. If you are not a veteran, you can email me at afternoonrounds@gmail.com and we can talk about it. And I may not be able to see you, but depending on where you live, I can refer you to some of my good friends who know a lot of the literature that we talked about here at this podcast and can kind of give you a personalized thing. But yeah, I also moved to Orlando from the cold Northeast, and I love it. I grew up in Central Florida, so it's great to be back, and it's great to be back with other plant-minded folks like yourself. So I look forward to more conversations on plants and health and warm weather.
Yes, I mean, Shivam, I have many people to introduce you to. It's going to be super fun, and I got you. So we're going to get you like integrated into this world, and I'm looking forward to just many more connections and conversations together. And Dr. Joshi is a great nephrologist. He's not going to be able to answer personal questions in detail on your emails, so don't expect that from his email. And it was so kind of you to give that out. But if you are a veteran, you are so lucky if you have kidney disease that he's here, and go seek him out, and because he has some pretty fabulous stuff to offer. So thank you so much, Shivam, for coming on and helping me with this and debunking some myths. And maybe if you could do me one favor is tell everybody at home who's listening to this, one or two things, like something that should give them hope with their kidney disease or with this process of changing their lifestyle. What would you say to people to empower them to make the change?
That you have control of your destiny. If you have kidney disease, you can eat healthy, make the changes so you don't end up on dialysis. And even if you're on dialysis, there's even some literature to show that eating healthy can even reduce your risk of dying on dialysis, and help you feel better and reduce some of medication. So you are what you eat. It's never too late, and it starts with your next meal.
One step at a time, baby. We got this. Great to see you, Shivam. Great to see you.
Likewise. Thank you for having me.
so much for being here. Yes, lovely.